Welcome to question set 14. Let's get started. First question, how does the treatment of acute gout differ from the treatment of chronic gout? So gout is a type of inflammatory arthritis that's caused by high levels of uric acid, which precipitates out of the blood as urate crystals, which then get deposited in the joints. We treat these acute attacks or acute flares with NSAIDs, and indomethacin is one that's classically used, although you could use ibuprofen or naproxen or even a COX-2 inhibitor like celecoxib. There's nothing particularly magical about indomethacin. You could also use steroids or glucocorticoids like prednisone. They work beautifully for acute gout. Then the other drug that's classically used for acute gout is colchicine, which works fine, but it also causes a lot of GI toxicity. So in practice, patients probably already been taking over-the-counter ibuprofen or naproxen before they come to you, so I just give them some prednisone and then they feel better in about 12 hours. Then for chronic gout treatment, you want to get the uric acid levels down, so you're going to either give allopurinol, which inhibits xanthine oxidase so they aren't making uric acid, or you give a uricosuric drug like probenecid, which is actually going to help them excrete more uric acid in the urine. And you can also instruct them to avoid purine-rich foods like red meat, organ meats, smoked meats, aged cheeses, and red wine. And I'll just remind you that you never want to start allopurinol during an acute attack of gout, because that can make it worse in the short term. If they're already on allopurinol, you wouldn't stop it, but if they aren't on it, you don't want to start it until that acute attack is under control. And then, why is allopurinol sometimes used in patients with leukemia and lymphoma? Well, when you treat leukemia and lymphoma, you can cause a massive lysis of cells. And those cells release all those purines and the patient uric acid levels can rise. So we're going to give allopurinol to prevent the patient from getting urate nephropathy and gout. Next, when performing a femoral arterial line placement or femoral venous catheter placement, it's important to palpate the femoral artery to determine where the inguinal structures are located. So what structures are found under and just inferior to the inguinal ligament? List them in order from lateral to medial. So there are a bunch of different mnemonics for this, but basically if you remember that when you go from lateral to medial, you're eventually going to reach the navel. So that's your mnemonic, navel. N is the femoral nerve, A is artery, the femoral artery, V is the femoral vein, E is for an empty space, and then L is for lymphatics. Next, a 54-year-old man presents with a blood pressure of 200/160, and the examination reveals a right-sided abdominal bruit suggestive of renal artery stenosis. What's the mechanism by which renal artery stenosis causes hypertension? So the kidney is perceiving low perfusion and low intravascular volume, which results in activation of the renin-angiotensin-aldosterone system. What are some other common causes of secondary hyperaldosteronism? So chronic renal failure can do this, CHF, cirrhosis, and nephrotic syndrome. Basically any scenario where the juxtaglomerular apparatus of the kidneys perceives low intravascular volume. Next, Sertoli cells release a substance that acts on the paramesonephric ducts in order to prevent the formation of what structures in a normal male fetus? And then what other name is given to the paramesonephric ducts? So the substance released by the Sertoli cells is called Mullerian inhibitory factor, and that inhibits the paramesonephric duct, or the Mullerian duct, from developing into the fallopian tubes, the uterus, and the proximal vagina. Next, what's the mechanism of action for methylphenidate? So methylphenidate is an indirect sympathomimetic. It releases stored catecholamines like dopamine, norepinephrine, and serotonin, very similar to the way amphetamines work. And the second part of the question is, what are the signs of intoxication with amphetamines? So generally speaking, any stimulant can cause nonspecific signs like mood elevation, psychomotor agitation, insomnia, cardiac arrhythmias, tachycardia, and anxiety. Specific signs of amphetamine intoxication are impaired judgment, pupillary dilation, prolonged wakefulness and attention, delusions, hallucinations, and fever. Next, a 38-year-old man's AIDS is being managed by his infectious disease physician, who's decided to start him on trimethoprim sulfamethoxazole, TMP-SMX. Now, why would you place an AIDS patient on TMP-SMX when his CD4 count drops below 200? Well, the issue here is that at CD4 count below 200, you need to start prophylaxis against pneumocystis jirovecii pneumonia, which is sometimes called PCP. Next, what medication targets CD3 and is used to prevent acute transplant rejection? This is miromenab, or sometimes it goes by the name OKT3. Next, what are the effects of stimulating the amygdala? So the amygdala is part of the brain that's important for both memory and emotion. So stimulating the amygdala can lead to increases and decreases of the arterial blood pressure, increases and decreases of heart rate, That's why emotional states can make your heart race and raise your blood pressure when you're angry or whatever. You're sending signals from your amygdala to the autonomic nervous system. It can cause increases and decreases of GI motility and secretion. It can cause defecation and micturition, pupillary dilation or constriction, piloerection, secretion of various anterior pituitary hormones, movements related to eating, such as licking and chewing and swallowing, negative emotions including rage, escape, punishment, severe pain, and fear, sexual responses such as erection, copulatory movements, ejaculation, ovulation, uterine activity, and even premature labor. Next, a 50-year-old roofing worker develops a cough for the past month that's now associated with hemoptysis. Patient denies a smoking history or prolonged exposure to secondhand smoke. X-ray reveals a left-sided lower lung coin-shaped lesion. What type of lung cancer is suspected in this individual? Well, this is a non-smoker with suspected lung cancer. But the clue here is that this patient is a roofer, which puts him at risk of asbestos exposure. Now, a lot of times when we hear asbestos, we automatically think mesothelioma. But the most common lung cancer in patients with asbestosis is actually bronchogenic adenocarcinoma. Even without asbestos exposure, this is the most common lung cancer seen in non-smokers. And then the peripheral coin-shaped lesion definitely suggests bronchogenic adenocarcinoma. Next part is what's the appearance of asbestos fibers in the lung? So they're going to look like golden brown rods, and they kind of resemble dumbbells. They're called asbestos bodies or sometimes ferruginous bodies. And then what cancers are associated with asbestosis? One more time, it's bronchogenic adenocarcinoma and also malignant mesothelioma. And our last question, given each of the following deficits, list the corresponding affected artery. So loss of motor and sensation of the leg and foot is the anterior cerebral artery. Visual fields deficits are seen with strokes of the anterior communicating artery. Aphasia with generalized sensory and motor dysfunction. And generally this is going to be a stroke in the anterior parts of the circle of Willis, either the middle cerebral artery, the MCA, the anterior communicating artery, and the anterior cerebral artery. Motor and sensation of the face is the MCA again, and then motor and sensation of the arms is also the MCA. So either the face or the upper extremities or both. And that's it for set number 14. I'll see you next time.